tackling diabetic retinopathies, and this will be our first session introducing young ophthalmologist speakers. And we are awaiting Dr. Ahmed Salam to join. And I guess we can start with Dr. Joshi presentation right now. Dr. Joshi is the director of Joshi Eye Institute in India, and his talk today about tackling the diabetic retinopathies. Please, Dr. Joshi, can you share your screen?
Sure. Yeah, I hope you're all able to see the screen.
Yeah, we can see it now, right now. Thank you.
Okay. So good evening, everyone. At the outset, I would like to thank Dr. Mohammad Al-Amri for giving this opportunity, and thank you, Dr. Mohammad Awadallah, for giving a nice introduction. And please let me know in case I'm crossing the time, so that I can try to, just a second, I'll just try to, 1 second. Use timings. Okay. Right. I hope my screen is visible, Dr. Mohammed. Yes. Okay. So thank you very much once again. And so the topic given to me was tackling diabetic retinopathies, the surgical part. I think Dr. Ahmad Salam is covering the medical part, if I'm not wrong. So Dr. Amri asked me to cover the surgical part of the complex PDR surgeries. So I'll be just showing the videos so that if any questions, we can take it at the end of this webinar. I'll start my presentation. So this is how we see, very bad cases of the complex PDRs in the left. And with the help of the improved visualization, instrumentation, now we are able to give a very good results in these kind of cases. You see there in the left, this is the pre-op of the patient, and this is the post-op picture, day one. You can just have a very good media as well. So I'll just start with a few of the videos. This was the patient who presented with me for PL positive, PR accurate, and almost the patient was in the tabletop TRD as we see here. And under very guarded prognosis, I went ahead and started doing vitrectomy. So as you see here, this was the earlier cases when I first started to do it under Ngeunity, that is the 3D visualization system. So what I'm doing here is the cutter segmentation. So for the interest of the fellows who are here, so this is when you try to cut across the membranes, it is called as cutter segmentation. And when you cut the attachment, it is called as cutter delamination. So you can make a small bit of cuts like this. But I would like to use a word of caution here. Whenever it comes to periphery and whenever you are seeing such sclerosed vessels and with the adherent membranes, it's always better to go bimanual. Use a good chandelier light. And what you see here is the fold back delamination as described by Dr. Steve Charles. So here you see, I'm just trying to pull it and then slowly try to cut it and then eat up the vitreous and the membranes with the help of the cutter. So slowly in all the quadrants, I'm trying to do step by step. You see here, I'm trying to go as much as to the periphery. It's always important to remove as much as membranes possible because these are the things which might give a contraction later. So as you see here, after removing most of these membranes, a base shaving is done in this case, and then laser being done to the brakes, and also the pan-retinal photocoagulation was completed. And then you can see the SRF being drained, silicone oil was injected, and then you can see the patient improved to 20/80 in this case. So this was one of the very nice improvement we had in these cases. Although what you see were the silicone oil reflexes, what you see in this case. So coming to the next set of cases, I'll just move ahead. So these are the cases again where you don't have a free edge to attack these membranes. So in these cases, you can use the picks or some kind of sharp instrument, make a small entry first, and then you start using your cutters. So thanks to these beveled cutters nowadays, which acts like a forceps and also like a scissor. Now you see here, I'm trying to lift as much as possible and then cut it around. 360 truncation, as described, is very, very important. So once you do a 360 truncation, and then you get the free edge of these membranes. So as you see here, I'm just trying to pull it. The membranes are coming very nicely, but in certain cases where it doesn't come, and it's better to shift to bimanual cases. But here, with the help of the cutter, I could get rid of most of these membranes. So as you see in this case, this is a case of unimanual where most of the membranes were removed with the cutter itself. I did not use the forceps at all, or the scissors in this case. Now, coming to the next set of cases, this is another interesting case where you see a flat TRDs. So, in these cases, you don't find an edge to enter inside. So, here, if you have the facility of IOCT, it is well and good. Even if you don't have, then it's nothing to worry. But I'm just showing the various uses, armamentariums, which we can use. So, this is the use of IOCT, where you can see the cleavage plane. So using that cleavage plane, so you can use this pick to go ahead, insert, and then use the cutter. So once you find a good cleavage plane and lift it, and now I'm introducing these cutters and then slowly do a cutter segmentation. So as you see, once you get a good grip of it, and then your job becomes almost very easy. Now you see these membranes come out pretty well. As you see here, with the help of the fold-back delamination, most of these membranes are coming with the help of the vacuum itself. I do not have to do more of segmentation. Now, ILM peeling was deferred in view of the thinning of the fovea. So in these cases, it is better not to do an ILM peeling. And here, and these are the another set of cases where you see the IOCT shows here on the right side, where is the cleavage plane. So you can always find your attack, or you can always find, try to push your instruments beneath that so that you don't cause an iatrogenic breaks on the retina. So as you see here, slowly trying to get rid of most of these membranes. And now, surprisingly, I saw there is a macular hole. So there's another interesting points with the IOCT where sometimes you do not know, but when you put across through the IOCT, these kind of small macular holes or the secondary membranes after doing an ERM peeling. So those can be identified and that can be easily removed. As you can see here, I'm trying to get most of these ILM over the macular hole and try to close it. So these are the another set of cases where you see this is a bloody red situation. In these, the Ingenuity filters actually help us to get, because in the detached retina with such bad membranes, removing these membranes becomes very difficult. Now I use the reduced red filter. Now you can see how nice the fluorescent kind of things these membranes come across. So you can cut most of these membranes easily without causing much of iatrogenic breaks. So this is the another advantage where you can adjust with the hot colors, cool colors, so that you can have a better visualization of these membranes. You can see here, I'm trying to shift the colors. So what best suits, whether it's a phakic, pseudo-phakic, aphakic. So based on that, you can definitely adjust your colors from 3700 Kelvin to 2700 or even more than that. You can try to definitely adjust it. So these are again a case of PDR where I'm showing a 27 gauge vitrectomy. I'm not a very big fan of 27 gauge because these instruments bend a lot. So I always have the trouble in reaching the periphery, especially when you have most. But for the posterior pole surgeries, I think it is really good. So here I'm just showing use of various digital colors, which might ease in doing the surgery. And once you do that, I'm just trying to put the BBG dye to peel most of these ILM. So the ERM is peeled first, as you can see here. And once the ERM is peeled, now you can see beneath that is the ILM. So here I used my favorite is the monochrome. That is, we come back to the black and white era where most of these colors are shut out. And with the help of that, see how beautifully you can distinguish this ILM membranes very nicely. But the disadvantage is you don't see the underlying retina or any blood. See, it get masked. So that you have to be a little bit careful about it. But once you get used to it, now you can see the pinch and peel technique actually decreases in these kind of using some of these filters, which help you in visualization. Because I keep telling my fellows, the more better you see, the better you do, and the better results you can give it to our patients. And finally, you can say I'm doing a fluid air exchange and completed the case. So this is the another set of case where, again, as I was telling about the multifunctionality of these cutters, this is a very good case to demonstrate about the cutter segmentation and the cutter delamination. See, initially how it looked, I'm just trying to show it. This was again a case of TRD, a tabletop TRD, where you can see most of these membranes which were adhered, and you can see in this, I have not used any scissors or forceps. So most of these are done by the cutter itself. Like how the cataract surgeons, they try to cut into different pieces and then try to emulsify the nucleus or the cortex. Similarly, what you're seeing here is try to cut these membranes into different pieces and then try to delaminate it. But the important here is try to disconnect the peripheral cortex to it so that it becomes very easy. I'm going an inside out technique here. I'm just trying to cut it into multiple, this thing, as you can see here, again, a cutter segmentation, and then finally a cutter delamination. See, multiple pieces, multiple this, and now you segment, you delaminate it. Carefully, with the help of a minimal vacuum, you can just try to remove most of these membranes, which come out really well with the help of these the new modern gauge cutters, increasing the efficiency of the surgery. And of course, you can use IOCT because there was a ILM folds. And finally, I did the ILM peel, and this is the post-op. The patient did really well in this case. So this is another set of case where you can see there is a macular traction here. And sometimes we see that, okay, this might cause a little bit of hindrance, whether to use those the forceps or whether to use the cutters in these cases. As you can see, after doing a peripheral vitrectomy, then you can attack these membranes in the posterior pole. See here, I'm just using this cutter like a forceps, just trying to peel as much as possible, not to push more further, otherwise it might cause an iatrogenic break, especially if we are under the macula. And slowly try to sniggle around these membranes and slowly delaminate it. Again, go ahead, go inside, find a plane. Some people try to do a visco dissection, but I'm not a great fan of using visco underneath these membranes. But I think some authors have already described it. It works, it might work best in their hands, but I feel it's slightly messier. I think with this technique, you can get a very good results as well. And finally, you can see I'm eating the last piece of this membrane. And once you eat up this, then put a PFCL, peel the ILM, and then this is the post-op picture of this patient. So coming to last two videos, again, you can see this is again when we went into, this is the, with the help of 20 gauge cutters, more faster, good efficiency. Of course, it's all linear dependent on the vacuum. Because you use high vacuum, it becomes more faster, but you can use with a less vacuum, it becomes more safer. As you can see here, it's the real time where you can cut these membranes. You see here, it's just 28 minutes of this patient which has been started, and you can finish within 30 minutes. That is the kind of efficiency we get with these the modern gauge cutters. Of course, knowing the techniques better is very important, so that we avoid any accidental breaks. So once it's done, wherever there are bleeders, please cauterize it. Otherwise, it's fine. Then you can see 1 week post-op, the optomap image. And finally, I just want to end with the help of showing the digital filters where you can use it. I'll just come directly to the filters. This I have already shown. This is the monochrome, which I already shown beautifully. you can distinguish these membranes with the help of less dye. You don't have to put more dye, BBG dye. And as I said, it decreases the pinch and the peel technique, minimize trauma to the retina in the process of peeling. So once we do that, now I'm going to the next section is where using a green filter. Now you see here. So what's the importance? Why am I showing about this filter is these membranes sometimes kind of fluoresce, you know. So once it kinds to bring out the fluorescent colors, you can distinguish where's the retina and where's the membrane very easily. And you can dissect these pretty well without causing much this thing. And then you can cut most of these membranes pretty much easier. And now I want to show is the chromovitrectomy, where instead of doing using that, you can use a fluorescein in the vitreous, a very less fluorescein in the vitreous. So what's the advantage? Yes, it stains the stroma of the vitreous better. And now you can see with the help of this, with uh, you can use these membranes. You can peel these membranes pretty much easier. Now you see here I'm clearing the blood. Now you see how fluorescent the membranes looks. So just go underneath that, do a cutter dissection. So once you're done with the most of the part of the surgery, and then finally go ahead with the delamination. And then do a fluid air exchange. And this is the 1 week post-op optomap image of this patient. So just I wanted to end with the last one showing that we have started even doing the intra-op FFA using these filters. Now you can see in the case of rebleeds, you can see here the intraoperative fluorescein angiography, the arterial phase, the venous phase going on here. And then, so what's the advantage? You can identify where we have missed the NVEs so that we can laser it. And secondly, where there are non-perfusion areas. See here, these are the certain peripheral non-perfusion areas which were missed in the previous surgery. So these probably can be tackled, and this is called as the IOFA guided focal laser. Even to the microaneurysms, you can even do the focal laser. So those are the advantages of using the IOFA in these kind of cases. I think with this, I like to end my talk. Thank you very much, Dr. Mohammed and Dr. Amri, for this presentation. Thank you very much once again.
Thank you, Dr. Joshi, for a very nice and very illustrative
Sorry,
presentation.
I'm not able to hear you.
Can you hear me right now?
Yeah. Now I can hear you.
Thank you
Yes.
very much for a very nice and very illustrative presentation of all new techniques in tackling the very hard surgeries in diabetic retinopathy. Just one question, as usual. Do you prefer to inject anti-VEGF a few
Yes,
days?
yes.
This
I'm
is
I am
usual.
I'm a fan of anti-VEGF where I use anti-VEGF 4 to 5 days before the surgery. But I'm not great. I do not say that use it at the end of the surgery, but definitely before this, because as you see, most of these are very angry vessels with angry membranes. So these keep bleeding. So I always advise to use anti-VEGF before.
Yeah, because I can see most of the surgeries you presented the bleeding is less and less, which is an advantage actually of giving anti-VEGF. Also, what are your indications for doing ILM peeling in such cases?
Very good question. So basically, in these cases where there is a traction component is there, I would like to peel off the ILM is because in these cases, during 1 or 2 years, I have seen the epiretinal membrane growing back. And the patients keep telling that you have already done a surgery for me again, why you want to do it? So instead of observing in those cases, it's better. But whenever if you have a suspicion that it's a very thinned out fovea or thinned out macula, it's better not to touch or do an ILM peeling in those set of cases.
Great,
But
great.
if you're not able to do sometimes a complete PVD or in any cases where it's very adherent, then definitely the posterior pole has to be got rid of the ERM and the ILM peel as well.
Great. And since you have the Ingenuity machine and all those kinds of fancy filters, do you start your surgery right, like regularly with the usual colors, then you shift at certain stages, or you start certain filters from the beginning, then you
No,
shift.
no, no, not required. It's not required. It's just as I said, if you're a good photographer, you can use multiple channels, multiple lenses, zoom lenses, DAC lenses. I'm not a very good photographer, but definitely you can use a different variety of lenses. But most of these cameras also do a good job.
Okay.
So I
So you are
really
not
don't
using
do.
the filters
But
like a routine.
yeah, but in certain cases where I showed the ILM peeling, in certain cases where you want to do a bimanual surgery, then we shift colors.
Okay.
We preset it. We
Yeah.
preset it so that I don't have to sit and every time adjust my gamma, saturation, hue, brightness, all those things. Once or twice, you might have to spend a little bit time on these adjustments. And then with the newer, actually, in the newer Ingenuity, they have a very good called as tissue detail. So the only thing why I'm telling this is it's not compulsory that you need to have these fancy equipments, but if you have it, you just kind of do it. But I do not endorse it, telling that you should have it. But I don't start with the digital filters in all of these cases. Only in very special cases, yes, to use that.
Okay, great. I guess also one last question that I it was in my mind, cases that are challenging, that those cases with the rheumatogenic component where the membranes are very adherent and there is a moving retina, and then such cases are really difficult to dissect the membranes. What's your policy, and do you use like PFCL in such cases? What if you have a macular hole as well? So we have the whole combo of all
Yeah.
difficulties.
Yeah. So in cases of CRD, where we call it as a combined retinal detachment, where both rhegmatogenous and the tractional retinal detachment, in those cases, I usually advise to do an inside-out technique. Start peeling the membranes from the disc towards the periphery, because as you know, the retina is thicker at the center and the periphery. So never hesitate to do bimanual. I say,
Okay,
I tell to all my fellows, first stick to bimanual. If you do a good bimanual, you can always do a good unimanual. You should have a good control over both your hands. Be ambidextrous. That is how we learn as a vitreoretinal surgeons, and that is how you get rid of these membranes. Second thing is, if you have a macular hole in such cases, so I do the ILM peeling under the PFO. The instance, say for example, it's a very large hole, and you want to do an inverse ILM peeling. So just bring it and place it on the center of the macular hole. Under the PFO, it snaps. The ILM sits very nicely under the PFO. I have seen in most of these cases, the flaps doesn't get dislodged.
yeah,
Second thing, the PFO always gives a good counter traction.
right. It's a
So
good plan.
every time you don't have to peel which direction, where I have to peel. Oh, did I have any other tear? Most of these will be sorted out. So with a good PFO, it gives a good counter traction, flattens it. It's almost like how you are doing a normal Mac hole surgery.
Great, great. The problem is sometimes the traction is so strong that the macular hole is even elevated, and of course you have to release the traction first and settle down the
Yeah,
macular
yeah,
hole
yeah, definitely. So
in order
very,
to
very,
infect the
very,
PFCL.
very, very that is very valid point, Dr. Mohammed. Is without relieving the traction, please do not inject the PFO. Sometimes, if I have a break anywhere near the mid periphery or near the posterior pole, that is where we give an opportunity to the PFO to go inside the subretinal space. So, always first relieve the traction as much as possible and then go ahead with the PFO to inject it and then flatten the retina. Very good point. What you have said.
Thank you, Dr. Joshi. Excellent discussion and points to remember for all the attendees interested in such surgeries. Thank you very much.
Thank
And
you.
I guess Dr.
Thank you.
Salim won't be able to attend, unfortunately. So we'll go ahead with our great speakers today. We'll start with Dr. Omar Abu Madawi. بنطقه صح ولا؟
Yes, yes, exactly, Dr. Muhammad.
Hi, Dr. Omar. Nice to see you, and we are looking forward for your great presentation today. Can
Thank
you
you so
share
much.
your screen?
Yes, I will share it in a moment. Can you see my screen now?
Yes, yes, sir. Yes. Great.
Good evening, dear professors and colleagues. First of all, I would like to express my immense gratitude for having this opportunity to present my case among such panel and prestigious professors. It is definitely an honor. My name is Omar Muhammad Abu Madawi. I'm a fourth-year resident in Alexandria Main University Hospital back in Egypt. And today I will be talking about that in one of our own calls, we were urgently notified to assess a 7-year-old boy who has been hit by a sharp wooden object in the previous 24 hours, and he has been complaining of acute onset diminution of vision in his left eye since that moment. On examination, his right eye was unremarkable, yet his left eye showed an unaided visual acuity of counting fingers 15 centimeters, a full thickness corneal laceration proven by the Seidel test, well-formed anterior chamber with AC cells +4, and a traumatic intumescent white cataract with compromised anterior capsule showing a defect in the anterior capsule. As we can see over here, that was the site of the full thickness corneal laceration. The AC depth is well formed with a traumatic right intumescent cataract, and we can see on his lower lid the fluorescein stain used for the Seidel testing. Immediate repair for the full thickness corneal laceration was done by myself using a single 10-0 nylon non-absorbable suture. I avoided the creation of a paracentesis in order to reduce the suture-induced astigmatism that might result from that suture. Post-op medical treatment, B-scan ultrasound was done later on to exclude any kind of posterior segment pathologies. A month later, I was able to remove the suture and do a biometry. And the striking feature that I'll always look up to see in that biometry is the astigmatism, as that gives me an impression about the astigmatism created by the scar itself and as well as by my sutures. And as we can see now, I started the case by the creation of a 2.4 main port incision using a steel keratome. We can see that flying part of the cortex and the traumatic cataract indicating the presence of the anterior capsule. I did the synecholysis after placement of OVD in the anterior chamber. I was keeping an eye on the iris root so that no iridodialysis is occurred, and I was pretty lucky with that. I stained the capsule using trypan blue stain under the OVD in order to be able to see precisely where where is the site of the anterior capsule. And then afterwards, I went with the micro scissors in order to be able to raise the flap for the creation of a continuous curvilinear capsular axis. I will start doing my rexus using a micro axis, and then using this grasp, I will be able to do the superior 6 clock hours with pivoting my hand. And then using a second grasp, I will be able to do the inferior 6 clock hours, and we can all see the nature of the cataract. It is a bit cloudy. It is a bit stuck to the anterior capsule. I was able to do it, and then I went in with a bimanual irrigation aspiration cannula, and we can see that beneath my right hand, beneath the aspiration cannula, that part is a bit resisting the aspiration. So I decided to leave it to the very last. I went forward with the other parts of the cortical matter, the parts that will be easier to get. And after a while, and after switching hands, I kept aspirating it once, twice, and over again. And then at that particular moment, I saw why it's not being aspirated, because there is a capsular remnant that's stuck and it's fibrotic to that cortical part, and any kind of traction on that might lead to posterior extension and lead to loss of my support. So I went forward with cortical matter elsewhere. And now by a little bit of downward movement of the eye, I took a look at the equator to make sure that there is no posterior extension. I decided to grasp it using a microforceps and then to cut it. Yes, that part in the anterior capsule will be compromised, but it will be much better than leaving it, leading to post-op inflammation, or pulling it, leading to posterior extension. I went to the counterpart in order to remove the cortical load as well, as this might lead to post-op inflammation, but I was much more careful at that part because this will lead to capsular compromise in the other part, and that's the anterior capsule that I have right now. I was able to remove that part, and then I started the creation of a PCC, and we all know the importance of PCC in pediatrics because he's 7 years old. After instilling some OVD in the burger space, I decided that to create the PCC as central as I could, but as we can see, my attempt was to create a small PCC in the beginning to avoid being in contact with that fibrotic part that's available, that we can see down here, infranasal part. And as I'm rotating, my intention was to get it smaller and to rotate. I'm taking my time over here, avoiding any kind of tackling any fibrotic parts. However, at the very end, I got tackled by that precise fibrotic part that I wanted to avoid from the very beginning. I decided to pull to the center, and as we can see that it will do the thing that we all doesn't like as surgeons, as this pop that happens at that fibrotic part, we can see it might lead to extension and loss of the posterior capsule. So I decided to stop, go in with the retractor, and I can easily cut it using the retractor without any kind of traction on that fibrotic part. After doing proper anterior vitrectomy and cutting all kind of vitreous, I'm here making sure that there's no any kind of vitreous prolapse from my ports. And then using a spatula, I will do a sweeping action beneath my ports. These are the weak points that might lead to vitreous prolapse. And I'm making sure that there's no vitreous in the anterior chamber as well. And I decided to implant a single piece acrylic foldable IOL inside the bag in between both leaflets of the anterior capsule and the posterior capsule. It is a bit tricky, yet it's doable. And we believe that it's the best for those children. And as we can see that the IOL got implanted in the sulcus, not in the bag. So slowly I will let it unfold. And then using the side port, I will implant the optic in the bag. Now the optic is in the bag and the trailing haptic will follow. And then afterwards, I will dial the leading haptic inside the bag as well using a dialer without any kind of pushing, without any kind of traction exerted on either the anterior or the posterior capsule. This is how my case ended, as we also in moments earlier. And a month later, this is how the child seen. We can see that that part of the lens fragment that was left is completely absorbed, the patent and the clear visual access for that child, reducing any risk of amblyopia. He's a very happy child, me as well. The post-op refraction in his left eye was minus 0.5 sphere, minus 0.25 cylinder, and his unaided visual acuity is 1. I chose the name on cloud 9 for this case because at the end of the case, me and the child were both on cloud 9, and I would like to thank you all so much. Thank you.
Thank you, Dr. Omar, for a very nice presentation, and we are happy as well as you and the child. And let me check if Dr. Joshi has any comments about your nice
Yeah.
presentation.
Yeah. Thank you, Dr. Mohammed. Dr. Omar, I think that was a very beautiful presentation. You showed it step by step, which is very nice. Just one question I had. Would it have been better if you had used a three-piece since you are placing it in the sulcus rather than using the single piece?
No, actually, I placed the single piece back in the bag in between both leaflets of the anterior and posterior capsule. I totally agree with you that if we are placing an IOL in the sulcus, it will definitely be a three-piece, not a single piece. But in my own case that I just showed right now, I placed the optic and both haptics inside the bag in between both leaflets of the anterior and posterior capsules.
So did you try to do
I
an
was
optic
going
capture?
to ask the same question.
Yeah.
The
Did you do an
3D.
optic capture? You tried to
Right.
do since you have placed it in the sulcus. So did you do an optic capture in this case, or
The entire IOL is inside the bag, the optic and both haptics.
it's in the bag, not in the sulcus?
Yes, no, it's in the bag. Let me show you one more
Ah,
time. Just a second.
oh, sorry, because I understood that it was in the sulcus. Yeah.
When it was first inserted, it was in the sulcus. Then he got
Yes.
it inside the bag.
Okay. So then that's the reason you have done it in the single piece. Yeah.
Yeah.
Yes, and now
But
we
again, this was exactly my case. If or my debate, if it was better to insert a three-piece,
Three
especially
piece.
with the compromise of the bag by doing the posterior rexes. Usually, we do this if we are going to capture the optic through the posterior capsule. Anyway, it's a nice surgery and a happy ending, as
I
you
just
have.
wanted to ask, did you use IVTA? No, you don't. You don't use it to check the vitreous in the anterior chamber.
No, we don't use it particularly in children because of the risk of secondary glaucoma. We depend on our
Some diluted concentrations. I don't think it causes unless it seeps in into the vitreous. Very diluted concentration. If you put it in the anterior segment, the only thing why I told was sometimes near the wound, near the side ports, or of course the main wound will always be cleared, but sometimes the remnant, and later on, in some some cases, not in all the cases, but when we regret it, there's a small peaking of the pupil. Oh, there's a small tag there which has been left. Wish I could have removed that. So just to reconfirm or double confirmation, I just wanted to ask if you use routinely in these cases or.
No, we don't
And
use it routinely. We depend on our visualization and the sweeping action beneath the ports, as well as the stability of the IOL. After placement of the IOL, and I was very sure at that moment that there's no any kind of vitreous prolapse into the anterior chamber, any kind of movement of the IOL towards any side, this means that there might be vitreous even inside the bag, and I will go once again with vitrectomy beneath the IOL in order to cut those strands.
okay, thank you.
Okay, thank
Thank you
you,
so much.
Dr. Omar. Thank you, Dr. Joshi. And we'll keep moving to our next speaker, Dr. Mehmet Serhat Mangel, Professor, University of Health Sciences. And we are eager to see your presentation, Doctor.
Thank you, Dr. Avadala. Thank you, organizing committee and MEOM webinar, MEOM Academy. I am very happy and honored for the kind invitation. Greetings from Istanbul, Turkey. Our presentation topic is oculoplastic surgery. Our patient's sudden painful proptosis following orbital for pedal evisceration. We have no financial disclosure. 49 years old male who underwent evisceration was referred to our clinic 1 week after the procedure for developing symptoms of sudden painful proptosis. We show the image, the left eye, and history in the patients had penetrating ocular trauma to the left eye 20 years prior to surgery, as phthisis will be had developed and the patient had been uncomfortable cosmetically and surgical intervention had been decided. And the four-pedal evisceration had been performed with 20 millimeter silicone orbital implant with another hospital. A physical examination, we see the eyelid edema, chemosis, subconjunctival hemorrhage, pain that increases with eye movements, and protrusion of the orbital tissues and associated lagophthalmy. And the closure of the eyelid, we see the orbital tissues in protrude. Why might proptosis develop? Intraoperative forgotten foramen body in orbit, orbital inflammation secondary to orbital implant, orbital abscess secondary to implant, hemorrhage in orbit, and rapidly growing malignant orbital tumor. Radiologic imaging orbital MRI, we see the T1 and T2 image revealed hyperintense area surrounding the implant, which was consistent with hemorrhage. We see the axial and the coronal images. We see the sagittal images and consistent with orbital hemorrhage. In the patient detailed history, the patients have diabetes mellitus, chronic renal insufficiency, and was under anticoagulation, and there was no history of trauma following the first surgery, and anticoagulant therapy had been castrated 1 week before the surgery. What should we do in the treatment in this patients? We give non-steroid anti-inflammatory drugs and ice compress for pain and hemorrhage and follow-up. We give intravenous pulse steroids. We do enucleation surgery. We do surgical drainage immediately for hemorrhage control. Intravenous pulse steroids. We do surgical drainage if there is no improvement. Continue. We choose the intravenous methylprednisolone, pulse methylprednisolone, 1 gram, 3 days. But despite steroid therapy, there is no improvement. We see that there is progression in the proptosis. This is the front image and eye closure. What is the choice? We check the surgery. And firstly, we open the conjunctiva, and then we open the tenon tissues. In the first surgery, another surgeon was performed four-pedal evisceration surgery, and we see the first flaps. We dissection, blunt dissection. We dissected the first flaps, and secondary flaps. We see the hemorrhage in now, and brown colors in hemorrhage we see, and we see the silicone implant. We see the hemorrhage focus in the retro implant, and we do bleeding control, cauterization, and adrenaline tamponade, and we see the cauterization, and we take a biopsy for different localization in this surgery, and then we reinserted the implant, and we closure the posterior and anterior flaps, and we complete the surgery. And this is the early postoperative period. The patient's the pain relief and the orbital contents improved, we see. In the late postoperative period, the patients have no pain, and we then prosthesis in the left eye. This is the before the surgery, and this is after the surgery. Initial examination the patients, and following steroid therapy, the findings in bad, and after the surgery, the findings is improved, and this is the last examination. Why might hemorrhage have developed? Firstly, surgical technique, implant material, patient's comorbid disease, and anticoagulant use, failure to carefully control bleeding during surgery, and inadequate removing of choroidal tissues during surgery is very important issue. We take a biopsy intraoperatively, and we see the choroidal tissue, and in the first surgery, failure completely excise the choroidal tissue in the first surgery. This is a very important issue in the evisceration surgery. And the patient has diabetes mellitus, chronic renal failure, and is using anticoagulants. These factors is triggered the hemorrhage, maybe. And surgical techniques, four-pedal evisceration, and two scleral flap technique, other techniques. The four-pedal evisceration techniques may be triggered the hemorrhage for more invasive techniques, more than two scleral flap technique. And the other debate issue, implant material, is silicone implant, acrylic implant, porous implant. Silicone implant may be triggered the hemorrhage compared to porous implants. This is the debate and discussion issue. And Robert Bruce Salter says our decisions are more important than incision. In these patients, we firstly choose the medical therapy, but after we chose the surgery. To our knowledge, this report represents the first case of early orbital hemorrhage developed following four-pedal evisceration. And in this complex case, prompt recognition and appropriate surgical intervention are crucial for the management of hemorrhage and preserving orbital function. In this case, it's currently accepted in Journal of Current Ophthalmology, recently accepted. And thank you very much.
Thank you, Dr. Mehmet, for a great presentation. It looks nice and happy ending as well. And I think it's out of my and Dr. Josh's scope, which is the vitreoretinal, but I
Yes.
mean, the presentation is great and looks nice. But let me ask you, what at the beginning, actually, before any further investigations or CT scan, uh, I would have suggested that an infectious origin of this. I mean,
Mhm.
this painful and with the limitation. Maybe there is no systemic features like fever or something, especially in immune compromised patients, like with diabetes, renal. You can get mucormycosis or something like this. I mean, I'm not an expert in this, but it ends up that all this is kind of a hemorrhage, which is, as I understand, is a kind of a rare after this kind of surgery. So can you
Yes.
elaborate much for the young ophthalmologist? How would you differentiate the hemorrhagic reason from an infective one?
Thank you for question, Dr. Awadala. Infections problems, you said, and in systemic problems, in fever, and the eyelids, in hot, and secretion, coprolan discharge, secretion, and this, but this patient have no fever, have no eyelid secretion, coprolan suggestion, and we in the differentiate for infections and hemorrhage, we take radiologic imaging is very important, and we consult these patients, these radiology doctors, and they say to me this is the orbital hemorrhage, and the clinical findings is existent the orbital hemorrhage, and we decided firstly medical therapy in this patient, because we know in proptosis cases in such as thyroid eye disease, Graves disease, steroid therapy may be alternative to surgery for relieve the proptosis. But despite the steroid therapy, the patient's findings and proptosis is increased, and the final choice is surgery. And this is the very rarely cases. This is my first experience in about this, and recently published in international journals.
Great. And can you tell us more about how the material of the implant can be a risk factor for bleeding?
Yes, we searched the literature, and silicone and acrylic implants more than trigger the hemorrhage compared to porous implants, and this is the more important factors. And these patients have first in this patient's message is important. In first evisceration surgery, we should excise choroidal tissue is completely. In this patient, the first surgery did not excise the totally choroidal tissue, and we take a biopsy intraoperatively, and we consult the pathology, and these tissues and related to about choroidal tissues, and this is the more prone factors for orbital hemorrhage.
Hmm. Okay, that's why. Dr. Joshi, do you have
Yeah, and just one question. I think the four petal versus the two petal evisceration, what you said, I think four petal has more advantages because the implant exposure or the migration is very less in these cases of the four petal. I'm sure that while you were scraping it and you have taken the histopathology report as well, and did it come for any infectious agent or any of these when you sent it for the culture? Did you find out anything just to rule out any infectious pathology?
In clinical findings, we don't see infections material, and I agree to you. We don't aspirate for microbiology for infectious agents. I agree to you. And for pedal evisceration technique is more invasive, the two-sectoral flap technique. We currently choose the two-sectoral flap technique for evisceration to prevent the immigration of the implant.
Yeah. Yeah, I agree, because with the four petal, the implant motility, I think, will be
Yes.
slightly better as compared to the two-step. Wonderful case, Dr. Mehmet.
Thank you very much.
Thank you, Dr. Mehmet, for your interesting case. And I think the third presenter, Dr. Khalid, is not with us today again. So,
No, he's here. He's here, Dr. Muhammad.
Dr.
He's here.
Khalid is here.
Yeah,
Okay.
he's here. Yeah, yeah, yeah.
Hi, Dr. Khalid. Can you hear me or hello?
Hello, are you hearing me?
Hi. Yeah. Hi, Dr.
Yes.
Khalid. Nice to see
Sorry
you.
for being late because of some connection problems here in Yemen. So
Okay.
again, I'm sorry again for that late.
Please share your screen.
I'll- Okay. Good evening, my professors and my colleagues. Today, my case presentation, I'm going to talk about optic disc pit maculopathy, the promising management and the outcome. Our case was a 24 years old gentleman was complaining of decreased visual acuity in the right eye for 8 months. He's a known case of any chronic disease with no history of any ophthalmic surgery. During the clinical examination, the visual acuity was counting finger to meter in the right eye, 20/20 in the left eye, according to the best corrected visual acuity. Unfortunately, there is no improvement in the right eye. The intraocular pressure was within normal, equal in the both eyes. And regarding the fundus examination, we noticed that there is an optic disc pit in the infratemporal region with the central serous retinopathy. We advised the patient to do OCT macula for more further management. We can see here in the OCT, there is excessive accumulation of the fluid in the subretinal layers with increasing in the thickness of the macular layers up to 1,000. So what are the management options that we have in such like these cases? Actually, there is no rule or there is no standardized management in such like these cases. But according to the previous paper research, there is a previous surgical trials advised to do laser alone or gas alone or using the both laser and gas. Some of them advised to do scleral buckling and others advised to do vitrectomy. We decided to do or to go with multiple techniques, starting by cold vitrectomy, internal limiting membrane stuffing in the optic disc pit, inner retinal concentration using 41 gauge cannula, laser photocoagulation, and gas component. Actually, the surgery was done by Prof. Nabil Tarish, who is a vitreoretinal consultant in Maghrabi Hospital, Sana'a. After starting to do core vitrectomy, as we see here in this video, we tried to inject trypan blue dye to start to do internal limiting membrane peeling. We try to be very gently above the macula to avoid macular hole as a complication of the peeling. And after peeling, we now stuffing the peeled internal limiting membrane into the bit to prevent the more recurrence in these cases. As we know, the recurrence is really high in such like these cases. Now, we also continue with peeling and stuffing the internal limiting membrane. After that, we can see here, we will use laser photocoagulation now. And we tried to choose it in the temporal region of the optic bit to prevent the recurrence after concentration, as we see here. The concentration to discharge the residual accumulation of fluid in the macula. And now with the laser in the temporal margin of the optic disc bit. After that, we injecting the gas tamponade, also to relaxing the edematous macula. Okay. During the first week post-op, the visual acuity was 2400 in the right eye, and after correction, it improved to 2070, and that is a dramatic response in such like these cases in very short time. So we want to see how it is the anatomy of the macula after our operation. So we asked the patient to do OCT. As we see here, the accumulation of fluid is decreased. Also, the macular thickness is decreased up to 559. And during the 3-month post-operation, the visual acuity is improved to 2100 after correction. It shows us further improvement to 2070. The OCT in this slide, it was 3-month post-op. As we see here, there is also decreasing in the macular thickness and improvement in the thickness of the macula. After 2 years post-operation, the visual acuity was 2060 in the right eye, and after correction, it improved to 2030, and that's make us very satisfied. The surgeon will be satisfied, and the patient is very happy, and show us a good results. That's the last OCT for the patient. We can see here the macular thickness come to the normal values. So my take-home message is that there is no standardized protocol for optic disc management. So vitrectomy with adjacent multiple techniques could show us a rapid improvement with the low rate of recurrence. Further studies are required to compare the superior outcomes. That's my references, and thank you for your listening.
Thank you, Dr. Khalid, for a very nice presentation. And I guess we will have a lot of discussion about this topic, which is the management of which is very controversial and a lot of techniques. We'll start with Dr. Joshi's comments. Please, Doctor.
Yeah. Thank you, Dr. Mohammed. Khalid, I think this was a very nice case and a very good visual improvement, I must say, in these cases. Usually, we don't expect such nice visual improvement in these kind of chronic case of ODPM. The only thing is, how I would have done it is, I wouldn't have peeled it over the fovea, where I see that although you were mentioning that we should do that, but what I see was it was completely peeled, or very small remnant probably might have left over the fovea. If you see the pre-op, there was a very thin roof of ILM. It's almost like what we call as a draping of ILM was just removed. So these cases sometimes, although this case did not have, but they might open up and cause a macular hole. So what other thing I would have done? Of course, it's you have obtained a wonderful result with your professor. I would have just peeled only temporal to the disc and then try to tuck it inside. Because such large flap probably might not be required. Because even if you peel it from the temporal without touching the fovea, or temporal to the fovea at all. So just tucking that. The second thing is usage of amniotic membranes. So in 2 cases, I have used amniotic membranes, and in 4 cases, I have used scleral plugs. You know, the part of the sclera can be taken, cut, and just plug it. But I see that amniotic membranes also give a good result. They stay for a long time, unlike what usually happens in the cornea for the Steven Johnsons or any of these ocular surface. This thing they use it doesn't get dissolved. It stays there. I have 2 years history of the patient who just stays there. So basically, it is you have to plug the ODPM, that is ODP, optic disc pit, has to be plugged. So in these cases, any of these other adjuncts could have been done. The third thing is I would have a little bit avoided laser in these cases because you're already plugging it. And also the kind of fenestrations, what you did, I have no experience over doing those fenestrations, making a small puncture nits over because it's the papillomacular bundle. So I usually do not want to touch the papillomacular bundle I don't want to unnecessarily have the patient, because once if he improves and if he has the scotomas, then it will be, still worse. Not having vision is different. Having good vision with some kind of defects, I think the patient will not be that happy. But I must say that it's really 20 by 30 is it was amazing. I think it's a miraculous what I see there, and probably all these things could have worked together, but I would have gone one step by step, and not to use all the no all the arrows and the bows at once together. So but congratulations.
Thank you for
Thank
your.
you, Dr. Josh.
Okay, continue, Dr. Muhammad. Okay.
Very valid points from Dr. Joshi, and actually, this is almost the same, very close to what I have demonstrated. That peeling of the whole ILM, the whole area of the ILM, including the involving the fovea, which is very thin, and the papillomacular bundle. I would either use amniotic membrane to start with, or the temporal ILM, as Dr. Joshi said. And also, if you bring some of the OCT scans, maybe I've noticed that there is some kind of a defect in the macula. Have you noticed this, Dr. Joshi?
Yeah, there was a macular hole. I was about to ask that.
Yes.
Uh,
Can you bring
Dr.
Dr. Khaled this, please, this scan again?
Okay.
There's one of the scans there. Because a very valid point from Dr. Joshua that very thin drape-like ILM peeling.
But it is a zero hole. It's not a hole. I'll show you here.
Yeah, maybe this was
Yeah.
this is a very thin. Maybe I'm not sure if this is a full thickness hole or not. Yeah, it's a very thin membrane. Could be a remnant of what.
You can see.
Yeah, this is anyway. Anyway, it ends up with a great. I mean prognosis, and again, I'm not aware about the fenestrations and the value of fenestrations at Dr. Joshi, but sometimes some surgeons do the laser at the edge, and it works sometimes well. Anyway, thank you very, very much, Dr. Khaled, for a very nice presentation.
I want just
And
to give
yes,
a one comment
yes,
for
sure.
our professors. First of all, thank you for your valid points. Actually, I'm with you in a lot of points, but I must to show what is the misconceptions that we have. Actually, internal limiting membrane peeling over the macula, it's a very dangerous step. And a lot of surgeons try to avoid this step because of the healthy of the macula. So you have to be, or you have to have a very skilled points to go with this. That's the first one. The second one, amniotic membrane is an intelligent and a very beautiful path of management you chose. But in Yemen, we have a lack of these possibilities. So we try to not to think in this. Moving above the macula, I know it's something very dangerous, but if you have a good skills, as Prof. Nabil Tarish, mashallah, he is one of the best in Yemen here. He done with a good results, and the surgeon was happy. As I told you, the patient was very happy. Thank you very much, and I'll try to keep your valid points to my professors. That's it.
Thank you, Dr.
Just a point, Dr. Mohammed. Dr. Khalid, so since you're mentioning, see, if it's a large pit, sometimes I have also suffered the same thing, that the temporal flap might not be sufficient. The ILM flaps might not be sufficient sometimes if it's a large pit. So in these cases, what I have done is I have tried to drag under the PFO the ILM flaps temporal to the fovea, but not involving the fovea. It's always better not to touch, because I have burnt my fingers in this. Believe me,
Okay.
it gives away. It gives away very fast. So because that's the only tension which is holding up the MAC hole. before creating a map hole. So if at all the amniotic membrane is not available, or in case if the scleral ducts, actually the small scleral flaps, very small scleral flaps can also be used. Or if still not confident, then we can definitely take the ILM from the peripheral area and then slowly drag it and try to stuff it inside. That is the alternate options if none other adjuvants are available.
Thank you so much. As I mentioned in the last point in my take-home message, further studies must be done for such like these cases, because it's a very rare and lack of a lot of previous surgical trials. Thank you so much, my brother.
Thank you, Dr. Khaled. And also one last take-home message, that it takes a lot of time
Yes.
for the vision to improve. So
Yes.
we have to be careful about this point. We have to wait and for a long period of time till we get the best visual
So we
acuity.
need to tell the patient that it takes a
Thank
lot.
you. Thank you, Dr. Khaled. And I guess we have only 2 minutes left to conclude. And now, first, I would like to thank our great presenters today, Dr. Omar, Dr. Mehmet, and Dr. Khaled. And before all, my dear friend and colleague, Professor Dr. Joshi. And I would like to thank him about the nice videos presented. And of course, for the panel, we'll gather and evaluate the speakers, and of course, Dr. Al-Amri, as promised before, will get registrations and accommodation for the winners. I would like to conclude this session and thank you all and the attendees for a very nice presentations and fruitful discussion. Thank you. Thank you very much.
Thank you so much, Dr. Muhammad.
Thank you, Dr. Mohammed. That was a wonderful presentation. Thank you for moderating it so well. Thank you for involving me. Thank you, the rest of the presenters. Thank you. Good
Thank
night.
you, Khaled. Thank you, Omar. Thank you, Dr. Mehmet.
Thank you. Thank you.
Thank you.
Bye.
See you.
Bye-bye.